Welcome to HMA's Vital Viewpoints on Healthcare. I'm your host, Jen Colmonico, bringing you expert insights and real-world perspectives that matter. Our guest today is Maddy Shea, who is a proven champion for health equity with a focus on housing as a key driver of community health. Maddy works with health plans on their strategies to address housing insecurity and safety, with affordable housing organizations to finance supports so that residents can age in place, and with state and local housing experts to make housing safer, healthier, and more accessible. Maddy previously served at the CMS Office of Minority Health and since has built expertise in connecting siloed health and social care systems to advance housing as a cornerstone of community health. Maddy, I am really excited to have you with us today. This topic of housing and healthcare is so important. In our HMA conference last fall, we had a fabulous panel on it, and it was a packed house, and it was really just an interesting conversation. So there's so much to talk about here. We're really thrilled to have you.
Thank you.
So your early years sort of focused on health disparities. Probably before that was as big and well understood an issue as we know it is now. How did that take you to focus on housing? Talk a little bit about sort of your journey in policy work there.
Worked a lot in housing, but and before I even start, let me just say thank you so much for helping us bring attention to the opportunities to connect the health and housing sectors, because we can make life better for millions of Americans through better partnerships here. So I'm super excited to be here. Thank you. But I got pulled into the health and housing sectors, really the connection between them in a big way in 2006, when I was charged to start up a brand new Healthy Homes division in the Baltimore City Health Department. In the second poorest city in America, I was tasked to get funding and resources to make housing safer and healthier for children and families across the city that was related to and really address their health needs related to their home environments. We didn't have any money in the health department. I was pretty poor, a poor city. So I needed to forge public and private partnerships to develop the resources to do these big things. So I got a crash course, as often happens in public health, in what housing people did. I had no idea. Housing developers, what they did, how they were incentivized, housing lawyers, what they, cared about, as well as what our hospitals cared about, clinics, public health. So we were able to do really big things together. And since then, I have really, it just propelled me to think about how partnerships between these two sectors can solve problems that I've really encountered over the rest of my career.
Everybody loves good public-private partnerships, so that's an exciting place to start. When we think about housing issues, right? We think about scarcity, we think about affordability, we think about quality, and there's all sorts of different groups of people that affects. So how are you guys in this sort of new initiative at HMA? How are you thinking about, the different areas of problems to solve or people to serve? How are you kind of segmenting that?
I know for me, and I think for most of my colleagues, we look at where there are aligned interests across both sectors, and also where different organizations are all serving the same people. So examples of that would be children with asthma. That's a HEDIS measure. Healthcare organizations care a lot about that. A lot of them don't do very well on that measure of avoidable asthma costs. And really just people doing well who have asthma. Well, this is also a concern in the housing sector, where you have organizations that can make those environments better. Similar for people who have been unhoused and have a real long history of housing instability. Healthcare organizations care a lot about them because there's a lot of costs associated with that. But so do all the continuum of care, housing organizations, community organizations that serve them. So there's opportunities to work together. There's a lot of those. So it's looking at where there's aligned interests is a good place to start.
I know there's a lot of aligned interests, perhaps around hospital at home and aging in place, and we sort of call it different things based depending on which sector we're in, right? But that another area of where there's a lot of aligned interest?
Definitely. Well, there was a big movement to help people get out of institutions and into their homes. So when I think of hospital at home, where people had to go to a skilled nursing facility in the past, now they would be able to have their needs met in their own home, which is for sure what they want, what their loved ones want. Typically there's not a one size fits all, but typically that's what people want. And it's actually more cost effective for the health payers. So that is definitely an area of interest. Supporting aging in place is a little different because that's more preventive, but people with means all go into assisted living at some point. We all do. We all need assistance and supports. But if you're very low income and you've had a very hard life and you don't have others to lean on, you might need supports that aren't available there that you can't afford. And so that's another area where I actually do a lot of work.
And so thinking just about that issue in particular as an example, right? So those are, if I'm a housing developer, if I'm building affordable housing, am I thinking about that? Or is part of what you're doing getting the housing developers to think about, how they construct what I don't know, technology and physical supports? I mean, are we sort of changing how people are building supportive housing?
Yeah, or housing in general.
Or how, yeah.
We aren't. I mean, there need to be incentives, but we're seeing some great incentives at the state level. I'm working with an organization that's Virginia based. And in Virginia, in order to get points for your tax credits to be able to win the tax credits really to develop the property, they needed to show that they could increase access to healthcare. And so we supported them in their approach to that and their partnerships so that they could provide telehealth and have a partnership with a federally qualified health center to meet that goal so that they could actually develop a property. So state incentives are really important here. And of course, the federal government could incentivize that even more. But it won't happen on its own because the cost of housing is so high, developing properties, that putting in things for which there's no incentives is probably unlikely to happen, sadly.
So the incentives have to be aligned. How are those incentives being created? I know are there some Medicaid waivers that are being utilized? What are the different kind of sources of incentives?
So on building property, that's on the housing side. But there are incentives from Medicaid, not so much that I know on Medicare yet, to provide services. So we've had rental assistance services that helps people to get into housing, waivers that address really helping people to get into housing to begin with. So finding it and their pre-tenancy deposits, those screenings they have to go through, and then another set of Medicaid supports around staying in it once they're there. There can be communication problems they help with, communications with landlords, things of that nature. And then Medicaid waivers are also paying for housing modifications. So if someone has a surgery and can no longer go upstairs or has other mobility issues, Medicaid dollars can be used to make those environments safe and accessible, and also for the health of them for people with asthma or respiratory illnesses.
For those modifications, presumably that's cheaper. I mean, even though those stair elevators are not cheap, but they're cheaper than somebody going into, an institution, right, or assisted living.
Oh, yes, significantly. In order to get approved for a Medicaid waiver, OMB had to approve that there was strong evidence of the cost effectiveness of each intervention. There's very strong evidence around the cost effectiveness of home modifications for people that have accessibility barriers. A fall is very expensive, Jen.
Well, right. And I'm glad you mentioned that. I was going to actually just talk about hospitals, as another kind of interesting partner here. You don't always think about hospitals as being interested in housing, but you see certain hospitals building housing now. How are those opportunities coming about?
Well, in New Jersey, the state incentivized hospitals to expand recovery housing. So that's for people who've been unhoused. You don't want to take them from a surgery or some hospital procedure back to the street because they're going to be right in that door and the hospitals are going to get penalized for that readmission. So the state actually incentivized hospitals in New Jersey to look at their own. A lot of times they have a lot of property and developing recovery housing or other housing, sometimes workforce housing on those properties to solve these access issues and the quality of care issues. So I see those more at the local level than anything, but housing is very local, as is healthcare.
I think it's so interesting because, hospitals have this sort of bricks and mortar problem in some instances, right? As we're looking to transition more care to lower cost or more appropriate sites of care in the community that would be at home or clinics or whatnot. They have these big buildings. So it's sort of like sometimes you think like, well, could you convert that? And, are there incentives to convert buildings to other uses that are, relevant and part of the continuum of care, but not necessarily part of a hospital's mission, depending on the system.
That is happening. I don't know as much about it as I wish I did right at the second, but I do know that's happening. I'm pretty sure in Virginia, and some other places, and also empty office space. It might not be their hospital facilities, but some of their administrative facilities as more people are teleworking or, hybrid models. They don't need as much space.
Right. No, that makes sense. It's innovative, right? I mean, there's a need and there's incentives and it kind of makes sense. Um, what, talk about like what do people need to understand about this opportunity? Like, is there something that you wish more people would understand about it seems obvious, right? All of these things like, wow, that's a great idea. Let's just do more of that. But what do people kind of not understand about what it takes to make these systems work together?
They have completely different language, completely different time horizons. Housing organizations think in terms of 10 years, and 30 years is when they would have to get the return on their investments. So whereas for healthcare organizations, they have a very, very short time horizon. And that is one of the difference in language, the difference in, when you've got to show your board or your stakeholders your results is a barrier, but I think it's one that we at HMA, we definitely know how to work through those differences. Because what we really need to focus on is particularly HUD-assisted housing, low-income housing. The millions of people in those settings are the same exact people that healthcare organizations are trying to serve. So we need to keep our focus on these are the same people. How can we do better by them?
Yeah. Do you find that data connectivity? I mean, I get when we talk about health-related social needs or social determinants of health, housing, of course, is always one of those components, and the whole notion of tracking the person, right? Not tracking, that sounds big brotherish, but if the same person is frequenting, frequent flyer in multiple systems, right? How are we connecting services in a more efficient way? So do you see progress on that as we keep our eye on that prize of, serving these same people? Do you see systems improving our ability to do that?
I don't. I think that's one of the areas that we really need to delve into now. Particularly on the housing side, they tend not to have the same data infrastructure and data sharing capabilities that healthcare organizations have and demand in their partners. But I think we're living in a time where we've got to work through that problem. I think we can solve for that. It's not even just that there's one healthcare data system. You've got all different ones going on there. So it's something we've been thinking a lot about, some of those of us focused in this area here, and trying to really put our heads together about solutions. But that is an area where we need solutions.
Well, in terms of like demanding those solutions or generating support for those solutions, maybe talk a little bit about the politics of this. I mean, it seems affordability is one of those words that everybody can agree on, right? As a you hear the language coming from all sides around affordability crisis and so forth. And this plays into that, right? Housing is expensive. It's one of the dynamics that we're sort of struggling with. So when you're talking about these partnerships and these opportunities in communities to do things differently, is it universally well received? Are there sort of different politics that you find in different areas or parts of the country that make this, differently complex?
No, I think that this is truly a bipartisan issue. I think it has been in Congress, particularly support for expanding low-income housing, because this does involve public and private partnerships. It's kind of using the levers of government to make things better for people. People suffer from lack of affordable housing in every state. Let's look at Alaska versus Hawaii, red and blue. Both have tremendous housing affordability issues, but it's all over. In rural areas, I've seen, where a lot of they're beautiful. People want to go there on vacation, and a lot of the affordable housing is bought up by Airbnbs and is no longer available for the workforce. So it's a workforce issue. It's an issue for, just residents of a state or community. So I do see that this is a great area of opportunity moving forward because it's truly bipartisan.
Are you able to, you talked about quantifying the cost savings of certain interventions and, home modifications, et cetera. Are you able to sort of quantify um, the, if you will, the wasteful or redundant spending? I mean, it seems like there's sort of a broader case to be made of system-wide, right, where creating these better partnerships may save us money. Are you able to pinpoint where money can be saved?
I definitely could pinpoint that the exact cost of the waste. I have never seen an analysis of that. But when I was at the Centers for Medicare and Medicaid Services, we did an analysis of, in the programs, the demonstration projects targeting people who were dually eligible for Medicare and Medicaid services. Was everyone doing as well as each other? Like, where were there disparities? And sure enough, those who had the greatest needs, who had due to disability or language access or other reasons, weren't accessing services the most. And in delving into that, those same people had care coordinators coming in from all over the place. Their special needs plan, their public health, their hospital, their, BH provider, so that's all waste. So what we have is a tremendous amount of providers going after a small number of people. They're not engaging any of them effectively. Whereas if we have more place-based solutions, such as working in a community that already has trusted, where the people that are being, are focused, who have these health-related needs, can just talk to people they already trust, either in their buildings if they're in developments or other people they interact with frequently, and have them be the quarterback for all of that care coordination. I think the savings could be tremendous.
Yeah.
That's just me speaking, but I think it could be tremendous.
No, I mean, it makes sense. I love the idea of place-based solutions, right? I mean, rather than having 14 different coordinators, it's sort of like an oxymoron, right? We have
That's
six
right.
different coordinators coordinating. It's probably not going to be very coordinated. Um, yeah, that seems like again, obvious and compelling, but in large complex systems, not always easy to fix. So let me ask you our favorite question. If you had a magic wand, what one thing would you fix that could kind of unleash progress in this area?
So I'm glad I knew you were going to ask me this in advance because having only one wish with my
Right.
mom is really hard.
Tough to pick one. I understand.
But I would make it much easier for housing and healthcare organizations to work together to create the conditions for vulnerable people, people who need it the most, to achieve their highest level of health, and it's different for everyone. I would take out these infrastructure barriers we just talked about. I would create a way where they can talk to each other, so that if someone came into the emergency room, maybe 8 times that past 2 weeks with a condition that really seems related to mental health and maybe social isolation, the ER could call, could communicate with the place where that person lives, and they could help with that. I mean, these are really simple things, but they're very high cost. So we take out those infrastructure barriers related to sharing data and communicating. I would wipe out the over complexity of accessing health and social care. People really don't even know what they're eligible for, how to access it. And even service coordinators, oftentimes find it dizzying to figure out how to do that. So that ordinary people like resident service coordinators or social workers could help people more easily. And you don't need, weeks of training to understand this complex system. And finally, I would make sure that these partnerships made the conditions for health better to begin with, which means providing more opportunities for social connections. Like a home is a home. It's not a prison cell, Health is about our social connections. It's about our social and physical environments. How can we make those better, so that we can really all be more resilient? Because when it comes down to it, I mean, that's really what we all need. We all saw that in the COVID pandemic. So how can we work together to just make the conditions better for health?
Yeah. Well, and it kind of goes back to where you started, meeting people where they are. I'm struck by a lot of what you just said, right? That's kind of thing has come up very often when we talk about a host of health related social needs and this kind of emerging awareness over the past couple of years of, the importance of addressing those health related social needs to maximize health. And we talk about meeting people where they are, and it, quite obviously, and yet not always obvious, like where they are is at home. And so like if that is the place from which this coordination happens, and it does make a ton of sense. And so as complex and difficult as that may be, does it have to be that complex? So that's a really interesting kind of a piece of the puzzle, I guess, that has sort of been there, but we're really elevating that now as a place to organize from, if you will, or organize around. So, see, it feels like there is progress. I know there's a lot of momentum. So, as you think about what you're working on, what you've been working on, what gives you hope? What types of innovations have, or accomplishments, what are the things that kind of give you some hope that we are making progress?
I know there's the will to do this, on both the health and housing sides. I'm hearing more and more uh, clients who want help with this and are willing to work through the challenges of that. So that gives me hope. And they've all been working on it for a long time. This isn't new.
Right.
People have experience. They're getting better and better. And then the other thing is that we've created this new health and housing practice group at HMA, and we have some terrific new colleagues who are joining forces with us to help our clients to work on increasing affordable, accessible, healthy, safe housing. And they're also helping us to expand our solutions to housing instability, that we see for unhoused people or people who've been chronically unhoused, as well as older adults that we talked about, people with disabilities, and other vulnerable families. So that gives me a lot of hope. I think we know what to do. We just want to be doing more of it.
Right. How do we scale it? Well, it's exciting. I mean, it seems like in the public policy world, when you have, well, I think you said it at the beginning, right? Where do the interests align? Where do you have a confluence of big, sticky, difficult problems to solve, and a lot of focus on that. And so, the focus on affordability right now generally probably helps. So, a good time for people to perhaps lock onto this as a way to solve multiple challenges by working together more closely. So. Um, I'm definitely excited to continue, track what you guys are doing. Welcome our new colleagues to HMA who are, have been doing this work, as you said, and bringing this group together is just really exciting. So, thank you for sharing that with us and sharing your time, and to be continued.
Thank you, Jen.
This episode of Vital Viewpoints on Healthcare is sponsored by HMA Information Services. HMAIS is a subscription-based service that provides state-level data on publicly sponsored programs like Medicaid. From the latest managed care enrollment, market share, and financial performance data to up-to-date RFP calendars and state-by-state overviews, HMAIS has all the information you'll need to power your initiatives to success. This podcast was produced by myself, Jennifer Colomonico, along with Tiffany McKenzie, in collaboration with our guests. The content is the property of Health Management Associates.